The Knowledgeable Provider podcast is intended primarily to entertain, also to inform, but it is not a substitute for actual medical training and should not be used by anyone to diagnose or treat any medical condition in themselves or others. If you need medical advice, please make an appointment to see your own knowledgeable medical provider. The opinions expressed by me and anyone else who happens to appear on the podcast are solely those of the people expressing them and are not necessarily representative of any other entities. Other than the lunches at the office, I do not receive any sort of compensation from pharmaceutical or medical device companies, and I have no other relevant financial disclosures. Look, this is all for fun, okay? Don't sue me. All right, on with the show. Welcome to Knowledgeable Provider. I'm Jody Marks. Today you'll hear an interview with my friend and former coworker and mentor, Patti Meiers-Singleton. We worked together for my first 2 years as a nurse in the Pediatric ICU, and I'm so excited for you to hear from her. She talks about all aspects of pediatric acute care, and if you're interested in this area of medicine at all, I think you'll learn a lot from listening to her. Patti previously worked as a registered nurse in the Pediatric ICU here in Huntsville, a pediatric hospitalist nurse practitioner, and finally a pediatric ICU nurse practitioner. She currently works as a nurse practitioner in the Pediatric ICU at the Medical University of South Carolina, Shawn Jenkins Children's Hospital in Charleston, South Carolina. She is also a clinical instructor for nurse practitioner students at the University of Alabama at Birmingham. Patti Meiers-Singleton, welcome to Knowledgeable Provider. Thank you for your time. I really appreciate it.
Yeah, thanks for having me.
Absolutely. You know, you're one of my biggest mentors that helped me out when I first got into nursing and one of my biggest role models in nursing. So it's really an honor to get to talk to you.
Oh, that's nice.
Fun fact, you know, everybody assumes that the PICU here in Huntsville, everybody assumes that the P stands for pediatric, but it actually used to be called the Infants and Children ICU, you know, the PICU, until Patti came to work there. And then they actually renamed it because of her. So
that's funny.
Local trivia. So I've already read your professional bio, but can you just give us a little bit of an overview of your nursing career and how you ended up in pediatrics and how you ended up where you are?
Sure. Yeah. So when I was in nursing school, I actually thought I wanted to work in the neonatal unit. And when it got to my last semester of nursing school, they didn't let you do your preceptorship in the NICU. So I ended up in the PICU and I fell in love. And I stayed there the rest of the time. So I started my first job in the PICU. I worked there for years before I went back to school to be a nurse practitioner. And then I did take my first nurse practitioner job was on the hospitalist floor, so just the general pediatric floor at the same hospital, and did that until they developed an NP program in the PICU. So then I went back to my home and kind of started the NP program back there before moving to South Carolina. So that's where I'm at now, but I'm still in the PICU. So I've always kind of done pediatrics. I love critical care, and that's kind of my passion.
What was it about PICU?
I think I liked just the variety, and I've always told people this that, have come and done, clinicals or whatever in the PICU, that the reason I find PICU so interesting and have for so many years is that we take care of such a wide range of diagnoses, as opposed to in the adult world, there's very specialized ICUs, so medical ICU, a surgical ICU, a neuro ICU, but the PICU kind of does all of those in one. And then you see all these different disease processes, but from anywhere, the age of like a newborn that's just a few days old up to 18 and even sometimes over 18 years old.
What are your most favorite diagnoses to take care of, or your most favorite issues to take care of?
I do like a diabetic that comes in diabetic ketoacidosis. I think it's a very regimented, protocolized treatment that is pretty routine. It's like bread and butter for pediatrics, I think. I like taking care of patients that, obviously I think are going to get better and go home. And so that's always nice to have someone, like a bronchiolitis or an asthmatic or some of those kind of patients that we see frequently. They're pretty cut and dry as far as figuring out what's going on with them and that kind of thing. Surgery patients, I think the more difficult ones are the ones that you might not necessarily know what's going on when they come in and requires a much more extensive workup, a little bit more of a unsure outcome.
Is there a lot of difference between the types of patients that you're seeing where you are now versus when you worked here in Huntsville?
Actually, yes. In Huntsville, we definitely took care of sick children. We took care of children on ventilators and blood pressure drips and, things like that. But here, we are kind of the referral center for the state. And so we get the things that the PICUs that the one I used to work in, would have to transfer out. And so I'm kind of seeing the other side of things where we're getting patients that can also be much sicker, which also, has its downside because obviously those patients have a, higher chance of mortality. But we also have all of the different specialists available to us, which was very different than in Huntsville, where we did have some subspecialties that we could consult to for pediatrics, but I feel like here we pretty much have any specialist we need. And so with that, we see a lot of different types of patients that are coming in for, more routine like surgeries and procedures and things that we just didn't do in Huntsville. So yeah, I've definitely learned a lot being here, taking care of like dialysis patients and ECMO patients and just things that I didn't see before.
That sounds great. There used to be all these issues with, is the adult service going to accept this kid? And is neurosurgery going to come in? Is trauma going to take them? Are we doing this? Are we doing that? It seemed like there was a lot of uncertainty about that sort of thing in Huntsville with some of the different diagnoses. So I'm sure it's nicer just to have everybody in-house and have what you need and not have to worry about it so much.
It is. And that is really nice. I will say there is something about having so many specialists that can also be challenging. In Huntsville, our intensivists were just so incredibly smart, and they were able to manage a little bit of, these kind of subspecialties without having to consult out because they had done it for so long and were such incredible physicians. Sometimes here I feel like, oh, we have to wait for pulmonology to come to tell us this, or, oh, we have to wait for endocrine to tell us the dose of Lantus when we could just kind of make one up, But it is nice, though, when you need the extra minds to come together. It is nice to have them just right here.
So like the PICU here is kind of a closed unit where you have the intensivist admitting the patients. Is it not like that there?
It is. Any patients that come to the ICU here, either we admit them solely or we co-manage them with like neurosurgery or general surgery, trauma, general surgery. But I guess I'm just saying, like, because we have this specialist right here and available, we don't make some of the decisions that we would have in Huntsville because they were going to not see them until after they left the hospital and they would follow up with them. For instance, like a diabetic patient who came in as a new diagnosis diabetic, we would often start them out on an insulin regimen and then send them to follow up with endocrine, where here endocrine gets involved right away, which again, I think it's great. And it's just funny that sometimes you have to wait around for, those specialists to come around to give their recommendations as opposed to just being able to do it yourself.
More cooks in the kitchen.
Yes. Sometimes that's good, but sometimes it's kind of nice just to do your own thing.
Right. As a mid-level, as a practitioner, how much autonomy do you have there?
I feel like I have a fair amount of autonomy as far as like being in an ICU goes. Obviously, like where you work in an outpatient setting, you see patients independently. And although you may have like a collaborative physician, they're not having to like see every patient that you see here. And in both ICUs I've worked in, all of the patients that we see are also seen by the attending physician. So I don't ever independently see patients like that are being admitted. That being said, we usually have between 22 and 28 patients on our unit, and only a couple of those are admitted in a shift. And so there's a lot of other patients that I will go see throughout the shift that I'm making decisions on and managing without having to have the physician see them also. Any admissions that come in or really critical patients are going to also be seen by the attending that's on. But I do feel like I make a lot of decisions independently, and they often, will ask, well, what do you want to do? So even when they're there and actively participating, they still will ask my opinion, and that's nice.
One of the things that our mutual friend Richard runs into working in the ER is that he kind of works with a different physician every shift, and so he has to adapt what he's doing to based on which physician he's working with. Do you ever run into that kind of thing?
Oh, that's exactly what I do. So I work night shift, and I've worked night shift pretty much my entire career. And the way our physicians work here is they have two continuity physicians that work the daytime. So they each have a team. They split our unit into two teams. And so they'll work for 7 days straight. And so the day shift is the same doc coming back every day, but each night is covered by someone different. And we have 12 physicians in our group. So every night I work, it's with someone different. So when I work 2 nights in a row, I work with 2 different physicians. And we also have residents. And so every week the residents change out. So every week I go to work, I have a new resident to work with, and then a different attending every night, which granted, I know the attendings after working there for so long. There's 12 of them. So eventually you work with them all a little bit, or enough that you get kind of used to them. But yeah, it is a little different, the way they like to do rounds at night, the way they like to do an admission, the things they want to be notified about, like all of those things differ from person to person. So it can be challenging, but it also is nice that you don't always have the same person. So if personalities or whatever are, not a great fit, it's just one night.
How are your interactions with the residents just in general?
This program that I'm in right now is relatively new. Like we just started in July of 2022. So prior to us starting, we had to have these big, I wouldn't say these, it was one meeting with the chief residents to discuss like what were our rules going to be at night, and were we going to be taking away opportunities from the residents and their learning and that kind of thing. And so I kind of was very nervous about it. And it's funny, the residents, so my partner, there's only 2 of us, and we cover 6 nights a week. So there's 1 night a week, every week that's uncovered. And then if we take vacation, those nights are uncovered because we don't have anyone to, fill in for us because it is such a new program. And so when we're, the night a week that's not covered is Friday, and the residents will, for the most part, I'll say that they hate Friday because they know we're not going to be there. When they start their 6 days, they're like, wait, you guys aren't on vacation, are you? Like, we don't want there to be a night that you're not here. And even our attendings, like if we take a vacation day, like they will text us and be like, what, you're not here tonight? And so it's really funny to see how well received our role has been by both the attending physicians and the residents. And it's just nice. It's nice to feel like we really do make a difference. People, even the nursing staff will say, the nights that you guys aren't here, it's so bad. It's so much nicer when you're here. And I think we offer just a very unique perspective because both of us have been bedside nurses in the PICU. So we can answer questions that the residents and the attendings can't about how to set up something or how to troubleshoot something as far as equipment or just logistically things to do with the patient. But we also understand things from the other side of the provider. So it's just a unique role to be in. And I think that we can teach the residents some of those nursing things, and that has really helped them a lot. Things that maybe they didn't want to ask the attendings, or maybe the attendings didn't really know how to answer and they didn't want to ask the nurses. And so we kind of are that person that they can kind of ask some of those questions that they have.
Well, that sounds really nice. That sounds like a very good middle ground between everybody.
Yeah, it is. I've been really happy, and it's nice when you hear people are like kind of fighting over you, like, oh, you know, I don't want to trade that day because that day doesn't have an NP on it.
That is amazing, especially for such a new program.
Yeah, well, and, there's always a resident there when I'm there, so I've never had to be there alone, well, until last night, but, I digress. But I think all the time, like, there's so much work to be done, I couldn't imagine being here by myself, and I have a lot of PICU experience, and a lot of these residents, they're just doing their, like, 1-month rotation through, and it may be their first time rotating through. I can't imagine how scary and difficult it must be for them.
Right, definitely. I remember being overwhelmed just as an RN working in PICU for, the whole time I worked there. What happened last night? Do you want to talk about that?
It was just a fluke thing where the resident had to go home sick. So I just ended up being there by myself and got to see what it's like. And I understand why they don't like Fridays. It's just it's a lot to try to handle everything with all the questions, lab calling with all the criticals, admissions. We respond to all the rapids in the hospital. I mean, it's just, it's busy.
I know that you have done a lot of transport and have also been receiving patients from outlying facilities a lot. Can you talk about some common, I don't know if I want to say mistakes, some common things that are done in like non-pediatric specialty facilities that you see coming in that maybe could be done better? Like maybe give some general tips for taking care of sick kids for people who might work in urgent care or a community ER or primary care or something like that, where they're not only seeing kids.
I guess the biggest thing I could say is that we see often places treat children like they're adults, and children are not just small adults. They have to be treated totally different. So, like a diabetic that comes in as an adult versus a diabetic that comes in as a child, we treat those totally different. And so, big things as far as like giving fluids, trying to be mindful of looking at the weight of the child and dosing medications based on the weight, getting a weight even is sometimes challenging.
Wow, really?
A lot of places are good about using the Braslow tape to get a weight, but sometimes they just are giving you like a guess, or like they look like they're about whatever.
Oh gosh, okay.
And so, yeah, just making sure that they're being mindful, or like giving way too much fluid to a small baby, or the drug dosages being way higher than they should be for a child. There's a lot of times that they'll call us when the child's only been there 5 minutes because I think they're so scared and
Sure.
we don't really have any information. And then there's other times where I feel like they've been there so long that they probably should have called us a little sooner because they didn't really necessarily know how to take care of the child, and they could have called earlier and gotten recommendations for things to guide them prior to transferring. A lot of our kids don't have IV access, which IVs in kids can be extremely challenging, especially for someone who's not used to doing them in children. Oftentimes we'll get children that have been stuck 8 or 10 times. And so then when they come to us, it makes it even more challenging for us to get IV access on them.
Can you talk about red flag symptoms that you look for in sick kids in general that maybe somebody more used to seeing adults might miss or overlook?
Well, I think one thing that people often don't check in children, especially like in these kind of smaller rural ERs, is blood pressures. Kids kind of can chuck along for a good while compensating, and blood pressures are going to be like the last thing that you're going to see that kind of shows that they're actually decompensating. And I mean, over half of the time when we ask what their blood pressure is, they haven't even checked one. Just kind of for your assessment of the patient, yes, they're tachycardic, but are they maintaining their blood pressure versus no, they're hypotensive. And so I think that's just like a big one, is getting a good set of vital signs and making sure you're using the right size cuff for the patient and that the information you have is good. I think level of consciousness is something that is often overlooked. I mean, an infant, it's easy to say they're sleeping, but are they arousable? We'll get something that's like, oh, they're just sleeping really good with mom, they're so sick, but they come to us and they're pretty much unresponsive. breathing fast is not always asthma. We have gotten many a DKA that came in for respiratory distress, treated with albuterol and treatments and things like that, and come to find out, no, they were a new onset diabetic who had Kussmaul's respirations.
I remember the albuterol issue being a big thing in pediatrics. Like albuterol fixes everything, right?
I mean, it fixes a lot, but but probably not diabetes. Babies coming in unresponsive, thinking about things like ingestions, and trying to get like a good history as far as, what meds are in the house. Unfortunately, tox screens aren't very helpful unless they happen to get into illicit drugs, but most of the time they get into like grandma's drugs. So getting a really good history of things that they could have potentially gotten into is very helpful. And, like, where were they? Were they at grandma's house? And you're asking them what drugs are in the parents' house. And they're like, oh, we don't have anything. But no, the baby was or the toddler was at the grandma's house. And then obviously like non-accidental trauma kind of things, if they come in unresponsive and you have low suspicion for, an ingestion or meningitis, that kind of thing, just kind of making sure that we're ruling out that they don't have like a big head bleed and somebody abused the child or something. The one that stands out the most, one time when we thought we were getting an ingestion of an unknown substance, and the patient turned out to be having a stroke.
Wow.
So, just sometimes what you're billed is not anything with what you get. So just kind of doing a little bit better job of like a history is often helpful.
Going back to the non-accidental trauma abuse situation, there used to be kind of an issue with everybody thinking it was somebody else's job to report that. And then, the patient leaves because everybody thought a different person was going to be handling that. Can you talk a little bit about how we should be thinking about that?
I guess I've always been under the mindset that if I report it and someone else reports it and it gets reported twice, that's better than me thinking someone else reported it, it didn't get reported, and nobody reported it. So I'm definitely of the mindset of, if I'm not sure, going ahead and reporting it myself. The good news about that is like usually the person, so if the ER calls and I call, it's usually the same person that it's getting reported to. So they can always tell you, oh yeah, we've already heard about this. I don't think there's any fault in reporting if you're unsure. I will say here, most of the time, the ER at either an outside hospital or my facility have already done it. And so unless they were billed as one thing and then they get to us and we're like, oh no, they have a big brain bleed and, fractures in multiple stages of healing, that kind of thing. And so here we have a specific social worker that we can consult, and they make sure that the DSS is called, that the police are called, all of that. And so it makes it easy for us because we just consult the social worker and then they take care of the rest. We also have a child abuse specialist here and a whole team here. So that's really nice because even if we have just like a low suspicion, we consult them and then they have the perfect kind of algorithm of things that they need to do to rule it out or what further testing we need to get, that kind of thing. And so it allows us the freedom to just take care of the patient while they're kind of doing more of the background investigation.
Yeah, one thing I always preach to my nursing students is don't assume that social work's going to do it or case management's going to do it or a supervisor's going to do it. Like you pick up the phone and you call the police and you report it.
Yeah, I totally agree that it would be on you if a child went home with, an abusive parent and something happened, and you had suspicions and didn't report it. So yeah, no, I definitely agree with that.
Maybe this is a good time to talk about dealing with the emotional aspect of working in pediatrics. You want to talk a little bit about how you deal with pediatric death or critical illness?
I mean, it's never easy when a child dies. Nobody wants to see a child die. Death is sad for adults. It's sad for elderly. It's just sad. But it's just even more sad when it's a child. And so I think that, over the years, luckily, we've had so many more children that I've gotten to see get better and go home. And that makes it easier when you have to think about the children that don't get to go home. And there's there's kind of a couple different categories I would imagine in my head of, the children that maybe have chronic illnesses that have been sick their whole lives or sick from a portion of their life until the time that they die. And, sometimes it almost feels like a relief when they pass because, they are no longer suffering. They are no longer having to live in the hospital, having, things that hurt and are not fun being done to them all the time. And, it gets to a point where you feel like their quality of life is not where maybe it used to be. And so sometimes it is a relief when you can see that they pass, and especially if things can be done kind of in the best way possible. And here we have a great palliative care team, and they work so hard to make sure that we can try to honor the families and the patient's wishes. And so we have done some very creative things as far as trying to get our patients outside or trying to get our patients to the beach or, something that can kind of make the situation at least somewhat better for them. And then kind of the other category of patients are the ones who were normal, healthy children that had something horrible happen, whether it be like a car accident or a drowning or some horrible illness. And I think those ones are so much harder because they just kind of hit you out of the blue. They're unexpected. They seem, just totally, unfair. And while they're all sad. I think those ones can be a little bit harder. I don't know. When my daughter was little, I always when whatever age she was, when I would see a child kind of her age, it was always hard to kind of picture that, that could be my child right there. But I think, it is part of the job, and being able to be there for the families and try to make something that's such a horrible situation for them the best that it can be, and hopefully give them some sort of positive feelings about how it happened, I think is kind of the best that we can hope for. And I really do try to strive to make sure that the family's experience is no worse than it has to be, and hopefully can provide them some comfort.
And I know from experience that you're very, very good at that. You helped me one night put together one of those, what's it called, a bereavement box? The little, lock of hair and footprint and all that. And even doing that with you when the family was not around, you were just so I just remember you were very, the only word I can think of is loving. And that really impressed me.
Yeah, we put those boxes together, and I guess it was one of the things that I always thought about was, I can't imagine how hard it must be for this family to leave and not have their child with them for the final time when they leave the hospital. And, the least we can do is maybe give them something, the blanket that they were in, a small memento with their hair or their handprints or something that just gives them something to take with them when they walk out.
And I don't have children, so it's sort of hard for me to put myself in that position. But that's one of the things I was going to ask you about is how you feel like having your own child affects just what you do on a day-to-day basis dealing with other kids.
Well, my daughter is grown up now, but she will tell you that I traumatized her by being an ICU nurse. So she did not want to drive. When she turned 16, I had to force her to learn how to drive. She didn't drive independently, despite having her license, until she was almost 18, because she was terrified of getting in a car accident.
Just from hearing your war stories?
I imagine that that's where she's getting that from. I also was always very, you have to wear your seatbelt. Children die from car accidents. You have to be safe in the pool. Children die from drowning. And I, don't ever take pills from someone. They could be something different than what they tell you they are. And you could end up in the ICU with all kinds of tubes in your body. And, so I did try to prevent her from, preventable harm as best I could. And I think may have caused her a little anxiety and trauma in the process. I also, on the complete flip side, probably underreacted when she was sick. And so she, being used to seeing, critically ill children, when she was mildly ill, I often kind of brushed her off. And so a couple of ER visits for like an asthma attack kind of opened my eyes that maybe I should pay more attention when she's wheezing. So, but yeah, other than that, I think it was always fun when I would have kids that were around her age and I could kind of talk their lingo and feel like I was cool. Now that my daughter's an adult, I don't know all of the current cartoons and shows and popular teenagers and that kind of thing. So I feel like one, I feel really old, and two, I'm not as, able as well versed when I'm like communicating with them about just trying to like, build a rapport or whatever. It was a lot easier when I had a younger child at home.
Sure. Yeah, I always used to struggle with that because the only time I was around kids was at work, so I definitely didn't know any of the current stuff. That's funny. I hadn't thought about that, but that makes sense. Can you talk about dealing with parents and families? I know that ends up being one of the big challenges of working in pediatrics.
Oh, yeah. So, not only do we deal with the patient, we have parents, grandparents, sometimes, siblings that are there, an extended family member, if we're lucky, that's a nurse or a doctor that can provide, questions via phone from 5 states away, So we're dealing with a lot. And of course, anytime a child is admitted to the hospital, people get, they're worried and upset. And so the whole family kind of gets behind them. So yeah, it can be challenging. It can be great too. I've made, I say friends loosely, but relationships with parents who have chronic children that are readmitted. And so we see them often, and it's, I think, comforting for them when they see someone they know and they're like, oh, good, you're on tonight. And they know that we know their child and they don't have to start at square one with what's wrong with them. They can start with since they were here last.
I remember feeling a lot of times like I was just there to be the big helper for the parent with some of the kids that had chronic illnesses because they were the boss, they were in the driver's seat, which is totally fine with me.
Yeah, and they're amazing. And some people I feel like get annoyed because they are so, opinionated and, just they want things done a certain way and whatnot. But I just kind of go with it because they are the ones that are taking care of this child every single day, every single night. Oftentimes these children are like complete care patients. And, we take care of them for 12 hours at a time and go home and get to sleep and shower and eat and all of that before we come back. And they are just there the entire time. And so when they want something done a certain way, I'm like, sure, unless there's, a reason not to, or it's harming the patient or whatnot. Like, I don't understand why I would ever fight the parent on something like that. And I think it just, they appreciate when we respect that that's their child and that they're the ones that are constantly caring for them and know them. And they're amazing.
Earlier in my career, it used to really make me mad, or I guess I had pride and thought I was supposed to know everything and be in charge and whatever. And when somebody would try to tell me how to do my job, I would, my feathers would ruffle. But I pretty quickly got to where I was like, oh yeah, all right, great. Let's do what you want. It's just so much easier. And in these cases, of course, they actually know what they're doing.
Right. Yeah, exactly. It's a little different when it's someone who maybe doesn't know what they're doing, or like their child is newly ill and they are familiar with adults and they're trying to use the adult kind of world in pediatrics, and that can be challenging.
I remembered another experience too when you were talking where we were up there in the middle of the night. It was just me and the mother. I'm in the room doing my care or whatever, and I'm changing the kid's diaper because I'm like, I'm the nurse. This is my job. I guess I have to change the diaper. And all of a sudden, this woman just like burst out in tears and said, "Can I not change my own child?" And I'm like, Yeah. Not only can you change your own child, I would love for you to change your own child. I don't know. I remember that being an eye-opening experience for me.
It is funny. Sometimes our parents of chronic kids, I think, are just happy to have a break when they come in. And so, some people will be like, oh, they just slept all night and didn't get up. And I'm like, they have to get up every other night of their life. Like, they don't even have to stay if they don't want to. So yes, let them sleep. I think sometimes people get annoyed. It's funny. It's like one of the two things. Either they're too involved or they're not involved enough. But I don't fault them either way. If you want to be there and help change a diaper at 2 a.m., sure. But if you want to sleep and let me do it, I'm perfectly happy to do that also.
Sure. Absolutely. That's a good point, that may be the only break they get.
Mm-hmm.
Do you remember the lady that named goats after all the nurses that took care of her kid?
Oh, yes. Yes.
Do you have a goat named after you?
I don't remember if I had a goat or not.
I don't think I ever merited a goat.
You didn't make goat status.
No, I never did. But I have run into her now and then, just out in town or whatever.
Oh, that's funny.
And the kid, and I mean, I still remember her. She still remembers me.
Oh, that's so nice.
Pretty neat. And it was really neat to see the kid grow up, after what happened to him.
It's one thing when we see kids that come back and are admitted over and over, and you get to see them grow up, but they're, obviously have a chronic disease, and that is the reason that you're seeing them over and over. It's so much nicer to see them out in the community when they're just like doing well and happy. And that's a much different experience in getting to see them, kind of thriving versus how they look when they're in the hospital.
Sure. Absolutely.
Being able to include the parents is actually a good part of my job. We have someone else at the bedside helping care for this patient that in the adult world you might not have. And so they're kind of our eyes and ears, and they know their children, and they know if something's not right. They may not know what it is, but something's not right. And so that is so valuable in helping us kind of find things earlier than we would if they weren't there, because they're not, always someone that we know and that we can just look at and be like, something's not right with this kid. So it's great to have the families. And I love that we have like a very family-centered unit. We have room for the parents to sleep in the room. They have a shower, they have a bathroom. We make it so that they can stay at the bedside 24/7 if they're able to. Sometimes it can be challenging having parents there. Sometimes they don't want you to do things that hurt, that their child doesn't want done to them. But we are doing it, because the child is critically ill and needs to have them done. And so having to kind of stop what you're doing to take care of the child, to talk to the parent and get them on board, just takes a lot of extra time. And sometimes that you have to do something and you can't do it because the parent doesn't want you to. And so, that's just a little challenging. And then sometimes parents just don't understand. They don't have the medical background or the ability to comprehend some of the things that we're talking about, despite trying to use language that's more understandable and that kind of thing. And so that can be difficult too, just having to kind of talk to two different people. You're having to talk to the patient if they're awake and alert, but you're also having to talk to the parents. There's lots of challenging things. And then there's the abuse cases and DSS cases for neglect and things like that too, that just add a whole extra element of fun to our jobs.
Yeah, I'm sure that's a super awkward situation when you feel like when you think you may be talking to the abuser in addition to the parent.
Oh, definitely. Definitely. And, and then until someone tells us that the parents aren't allowed to be there, they get to stay. And so it's very awkward. And yeah.
And I guess legally, I mean, really the parents have to consent to everything, right? Unless you're operating under implied consent because they're not there.
Fortunately, in the ICU, most things fall under like an emergency consent. So there's not much, and I work overnight, so there's not much we're going to do overnight that's not emergent. So if we have to put in a central line or put in a breathing tube or those kinds of things, it's because the child is critically ill and unsafe and an emergency. But let's say they need a planned surgery. If DSS has taken custody, they can do two different things. They can either allow the parent to still make medical decision making, even though, the parent may have to visit with someone else, like they can't come by themselves. Or DSS can take complete custody where they will sign the consents.
DSS, Department of Social Services?
Yes. Yeah. DHR in Alabama, DSS here.
Do you want to talk about COVID? You want to talk about what your experience was all through COVID?
Oh, gosh, COVID. So here in Charleston, we had just moved into a brand new children's hospital in February or March of 2020. So kind of right around the time that everything was just, shutting down everywhere and things. But we had a couple weeks in our new hospital to kind of enjoy all the new space and places for families and things like that before they shut it down and said no one could visit. I will say it was probably nice that we were in our new building because the old building only had a couple of private rooms and the rest were like curtains separating the rooms. And so for just COVID precautions, we had more negative pressure rooms here. We had more just actual private rooms that even if they weren't negative pressure, they were providing some kind of protection and just more space in general. So it was probably a blessing that we were already in the new building. I don't know if a lot of people know this, but because the whole world shut down, children were staying at home. They weren't going to daycare. They weren't going to school. And so they weren't really getting sick. And so children's hospitals across the country were not having very many admissions. And so our numbers dropped to really, really low, while the adult side of things was blowing up. A lot of places made the peds nurses go work in the adult units. And that was kind of how they helped fill the staffing kind of gap that they had. Our hospital, we actually took adult patients and admitted them to the pediatric unit. So we got to experience some of COVID in our own unit. So we had adult patients with and without COVID just to kind of help with some of the overflow from the adult world where they didn't have enough room for everyone. So that was very challenging. It wasn't a very popular decision, obviously. We were hemorrhaging staff because there was travel nurse contracts where they could make a killing all around the country. So they were leaving to go travel and make 2 or 3 times their salary. We were having to take adult patients. We were also the only unit in the hospital that took COVID patients initially. So any pediatric patient, even if they were only a floor status patient, had to come to the ICU. So that was kind of frustrating. Eventually, they ended up letting the floors take the floor status COVID patients, and that's kind of where we are now. But it just felt like, in the very beginning, the testing took days. And so anyone that was a rule out COVID had to come to us too. So we just felt like we were, kind of the catch-all for the whole hospital. We had to take all the patients, adult patients, pregnant patients, postpartum patients, things that we were very uncomfortable with. And we were doing it with less staff than we needed and all of the other challenges that everyone around the country was facing. So it was a bad time. And I don't think we've fully recovered the staff. I mean, there's probably over 50% of the staff that were there then are not there now.
Wow.
And I mean, I'm talking people who had been there for years. So a lot of people retired. A lot of people went to kind of outpatient surgery, same day surgery kind of places, PICUs, those kind of places, and left kind of traditional bedside. And then a lot of people went and traveled. And then you had your handful of people that went back to school and left for those reasons. But yeah, it's just challenging. And so, in the past, we always had a whole group of experienced nurses, a whole group of kind of your middle of experienced nurses. They've been there a couple of years, they know what they're doing, but they're not like the old school, know everything kind of people. And then you had like your new grads. And now I feel like we have mostly new grads or nurses with like 1 year of adult experience who then transferred to us. So it's just a very different feeling. People who have been here like a year are training people. And so you just don't get that same level of orientation that you did when someone with 10 years of experience trained you. And so, yeah, it's been very challenging. Staffing has been horrible. And, people are still doing the travel contracts, even though the pay has gone down quite a bit. It's still much more than the bedside nurses are making. And so all of the, younger nurses with no spouses and children, it's a good opportunity for them to make some money, pay off their loans, that kind of thing. And a lot of jobs have gone remote. So even people that are married, their spouses may be working from home. And so they just travel together. And so, yeah, it's just different. And I'm afraid that the years or the time of people staying for years and years and years is kind of over, because I just don't see that. It's kind of sad.
It is sad.
But yeah, COVID has definitely changed kind of just our staffing, I think, for good.
Sure. I know I definitely benefited as a new nurse from learning from all of the experienced nurses who had been there forever. And I can't imagine learning from only people who are still new themselves.
Right. It just changes the dynamic. But I do feel that that's one of the reasons that people are so like appreciative of the NP role, because we kind of offer some of that experience when there is a whole, shift of mostly newer nurses. If, they can't ask their neighbor because they don't know, they can come and ask us, and hopefully we know.
Sure. How much experience do you have at this point? How long have you been a nurse, if you don't mind sharing that?
23 years.
Wow. What was it like for you going back and trying to take care of adults after 23 years of just taking care of kids?
Oh my gosh, it was awful. Um, I we really, just did our best. I mean, we knew the basics, and they told us they were only going to send us like the younger, like patients that had less comorbidities and things like that. But then they didn't have any of those. So then we just got the kids, the adults, that was the hard thing. Like we were talking to them like they were children. We were, it was so difficult. Just even our verbiage and how we act at work was just different. It was just weird to like have an adult that you could actually like have a conversation with,
Sure.
be your patient. I don't know. It's just very odd. It was also really sad to see like an adult who had children who like didn't do well with COVID and passed away, and like that was a very different feeling. We're used to seeing the other side of it, but just thinking about like children growing up without their mom, or, I don't know, that was especially sad.
Wow. Right.
But yeah, we had some like crash courses from the adult educators on like, none of us are ACLS certified.
Y'all just have pals.
Yeah, we just have pals. And so I remember like having ACLS algorithms like taped to the wall.
Wow.
Yeah, that felt safe. And then like having to use like the adult insulin protocol and that kind of thing. And, that was very like, we all just felt so stupid. But we made a lot of phone calls to like the adult people, and their educators did some kind of video training sessions that we all watched and things like that, just kind of going over some of the main things. But yeah, it was an interesting time.
Did you have trouble finding equipment, like the right size equipment to take care of adults?
Yes and no. I mean, because we're part of the adult hospital, like we have access to the same central supply. So, we have adult beds and we have adult blood pressure cuffs and things like that. And what's funny is like the second wave of COVID, we got tons of kids. So we quit taking care of adults. And then we were like filled with very like obese adolescents with COVID. And so we, have to be prepared for those size patients. An adolescent that's 300 pounds is no different than an adult that's 300 pounds, as far as the equipment that you need.
Sure.
The job I was working at that time was a quality and safety job, and we had a ton of pressure injuries. And so we ended up getting like different products in and kind of changing some of our protocols and doing different training. And we got really good at some of that kind of stuff. And so it helped. We learned it on the adults, probably into some of the adolescents, and kind of changed our practice, for good.
I wanted to make sure and ask you specifically because I know that you were working as an NP here, and then when you moved to South Carolina, there wasn't an NP role. What was it like for you going back to bedside nursing after you had been in the nurse practitioner role for a while?
It was challenging, for sure. I think had I done it back in my old unit, it would have been like no big deal. But because I moved to a new unit that took care of patients that I had never taken care of before, it was like this, big learning curve for me, not only with having to learn, a new hospital, new policies, new equipment, that kind of thing, but also learning how to take care of like new types of patients. But with that, I will say I am so glad that I did that before becoming a nurse practitioner in this unit. I think it's just helped me be a better nurse practitioner, that I understand how to take care of these patients from the bedside perspective. It would have been very difficult to try to grasp the concept of ECMO and CRRT, having not ever, gone through the training and ran the pump. Well, the CRRT, not the ECMO pump. There's a whole group of people that do that. That is not me. But I think it's just helped me kind of understand things in a way that I wouldn't have if I had just moved here and taken an NP job in the PICU.
Got you. And I imagine it helps earn the respect of your coworkers as well.
I think so. I think they, it was funny. A lot of the physicians, when we interviewed, were worried, well, do you think that the staff are going to be okay with you guys like moving into a provider role? And yes, that's never been a problem. I think if anything, it's like they're happy to know that someone understands some of what they're going through. And so, yeah, that's never been a problem here at all.
Awesome. That's great to hear.
And I did enjoy doing bedside some of the time. Like some of the time I was like, oh, I can't wait to be an NP again. But, there's something to be said about having like a one-to-one patient and like just spending your whole night in the room with them and the parents and just getting that one-on-one time and just feeling like you really know the patient and got to really talk to the family and be like there for them. And that's something that you don't really get to do when you're having to cover, 26 patients. That was kind of nice, and kind of getting to make those little special bonds again was nice.
And I'm sure the patients and families appreciate it too.
I hope so.
If you had to give advice to future nurse practitioners about going into pediatric acute care, just as a specialty, what kind of advice would you have to offer?
I guess a lot of the questions I usually get are people that don't know if they want to do primary versus acute and which program should I go into. And so I always tell them, think about like where you enjoy working. And if you enjoy a primary care setting with, well checkups and, sick visits for a kind of like an outpatient setting, then definitely do primary care. But if you see yourself wanting to be in kind of a specialist office and urgent care and ER, any kind of inpatient setting, then I would recommend doing the acute care. And it's just the difference in like where you spend your clinical time. Obviously, there's classes that are associated with these too, but I feel like most people I felt like I learned the most in my clinicals. And so I would in no way feel comfortable working in a primary care clinic with my acute care degree. All of my clinicals were done in specialist office, ER, ICU, cardiac ICU. Other than the 40 hours of mandatory primary care we had to do, I don't feel comfortable, doing primary care. That being said, people that spent all of their time doing primary care, I don't feel like learn very much about inpatient hospital medicine. And so a lot of places and states are now requiring that your degree match where you work. But there are still some places where someone who has like an F&P degree can work in an inpatient pediatric unit. And I think it kind of makes things a little confusing because your training is all outpatient and you may have only done, some places only require like 40 hours of pediatrics. So if you only did 40 hours of outpatient pediatrics, I don't think that trains you to do inpatient pediatrics, so that's kind of, I always try to get people to think about like, where do you see yourself working and kind of pick your specialty that way. And then they do have dual programs for people that are just like, I just don't know. I mean, you can do both, but I know a lot of nurse practitioners who had primary care degrees that are having to go back and get their acute degrees because the hospitals are changing their requirements. And so, it's hard if you haven't gone through the program to know what you're going to like and what you don't like. But I do think it's important to get a degree that's going to be where you want to end up working.
I guess the things that are available in your area probably has a lot to do with that. I know some of our friends that I know that have gotten pediatric acute degrees are kind of limited around here just because there are so few places where you can work with that.
Yeah. And that's the thing. And I guess that's kind of, maybe I should have led with that. Like a lot of people are like, oh, I'm going to get an F&P degree because it gives me more opportunities for jobs. But to me, it doesn't give you more opportunities for appropriate jobs. Like if like I've only worked pediatrics, I love pediatrics, I want to work inpatient pediatrics, but I'm going to go get an F&P degree because then I could work anywhere. That doesn't make sense to me. If you want to go back to pediatrics. Yes, having like a dual degree would have opened up my opportunities, but there's no way I want to work in an outpatient clinic. So yeah, there might be more jobs, but I would never take it. I don't know very many places that would hire someone without an acute care degree to work critical care, but like we do procedures. And so we can do central lines, art lines, intubations, chest tubes, those kinds of things, where a primary care NP, I think suturing and LPs are kind of the only procedures that they can do. So it would be weird for us to work together and there's things I can do that you can't do, but we both have the same job requirement.
Sure, absolutely.
It's difficult. And I will say here, it's especially difficult because our state doesn't even have an acute care pediatric program. But now the hospital I work at requires an acute care degree for inpatient.
Oh, interesting.
So, which is going with what a lot of the country is doing. And there are tons of online programs. And so you don't have to go to an in-person program to get an acute care pediatric degree. There's tons of places you can do it online and then set up your own clinicals where you live. It's just funny that there's no like options around here, but it's a requirement,
Well, I guess if anybody has an acute care degree and needs a job, you should probably look in South Carolina.
I know.
I feel like this is a good place to stop. Is there anything else that you'd like to add? Anything else you thought of? Anything else you wanted to cover?
No, not that I can think of.
Well, Patti Meiers-Singleton, thank you so much for your time. It's so great to talk to you, and I hope everybody will benefit from some of your experience as much as I have.
No, it was fun. Thanks for having me on.
Absolutely. Thank you so much. Come back anytime.
All right, will do.
All right, that does it for this episode of Knowledgeable Provider. I'm your host, Jody Marks. Thank you so much for listening. Don't forget to like or subscribe or follow and leave a nice 5-star review. And as always, stay safe, take care of yourself, and take care of your patients, in that order.